Hello, everyone. I am Stephanie Coleman. I am the family autism educator here at Kansas LEND. LEND stands for Leadership Education in Neurodevelopmental and Related Disabilities, hence the word LEND. We are a workforce training grant where we provide leadership training to graduate students and postdocs to learn how to better support families and individuals with intellectual and developmental disabilities. So we're really excited to have you join us today for the Substance Abuse in Adolescents with Dr. Genovese and Dr. Ansari. This is a recording, so if you have any questions, there will be contact information under the recording, and you can always reach out and we can get you in contact with the correct people. So thanks for joining us, and I am going to turn this over to Dr. Genovese.
Thank you, Stephanie, and thank you again for the invite and the opportunity to speak on such an important issue for our families. And so Dr. Ansari and I are going to cover substance abuse in adolescents. And just to give you an idea of who we are. There we are. Sorry about that. I am a child and adolescent psychiatrist, a graduate at the University of Missouri Columbia, currently teaching and practicing at the University of Kansas Medical Center. Dr. Ansari is a psychiatrist who has recently completed fellowship training in child and adolescent psychiatry, currently practicing while completing his second fellowship, now in addiction psychiatry at the University of Kansas Medical Center. Neither myself or Dr. Ansari have any relevant financial interests related to the content of this presentation. Objectives of this presentation is designed to educate the audience regarding the extent of substance abuse in the adolescent population, and in particular, why autistic youth may be at elevated risk. Highlighted in the presentation is the evidence that effective mental health treatment and family-based prevention programs can reduce the risk for substance abuse. So I am a teacher, as I said. We often add pre-test and post-test questions. It helps to engage the audience, get you thinking, and give you an idea of what our focus is going to be in the talk. And of course, we will provide answers to the questions as we move along. And hopefully you will learn some important information that maybe you weren't aware of. So pre-test question 1. What percentage of adolescents in the 8th, 10th, and 12th grades endorse substance use according to the National Institute on Drug Abuse? Would that be 20% of 8th graders up to 40% of 12th graders? Would it be 10% of 8th graders moving up to 30% of 12th graders? Or would it be 5% of 8th graders moving up to 20% by the time they're in the 12th grade? So again, we will cover these statistics as well as the source of these statistics here in a minute. Question 2, according to the Centers for Disease Control, the CDC, what are the substances most often used by adolescents? And that's in descending order, from most commonly used to least commonly used. Would it be opioids most commonly, followed by cannabis, and finally nicotine and alcohol? Would it be cannabis, the most commonly abused substance by adolescents, followed by alcohol, then opioids and nicotine last? Or would the most common be alcohol, followed by nicotine, then cannabis, then opioids? And again, we will be providing information to help answer these questions. According to the Academy of Pediatrics, question 3, untreated or inadequately treated attention deficit hyperactivity disorder, what we call ADHD, increases the risk for what? So if it's untreated ADHD, it increases the chance for overall poorer life outcomes. That would be answer A. Academic underachievement, B. Risk of developing substance use disorders, which would be C. Or D, all of the above. And finally, successful treatment of other mental health conditions reduces the risk of developing substance use disorders. So other mental health conditions aside from ADHD, ADHD is actually a developmental disorder, similar in some ways to autism being a developmental condition as opposed to a psychiatric disorder. In other words, there are strong genetic factors involved with the risk of developing ADHD, as well as other mental health conditions. So is the successful treatment of these conditions, does it reduce the risk of developing substance use disorders, true or false? So the statistics are from the Monitoring the Future survey, conducted by researchers at the University of Michigan, Ann Arbor, and funded by NIDA, the National Institute on Drug Abuse. And so it's a survey that they administer to high school students, grades 8th through 12th. And certain schools agree to participate in the survey. So these are students who are in attendance, who are answering the surveys. The most recent data available to us right now is from 2023, and this was question 1, I believe. 10% or so of 8th graders, close to 20% of 10th graders, just over 30% of 12th graders are endorsing the use of substances. The numbers may seem high to some of you. We want to point out the fact that most youth are not using, so that's the good news. And most youth who experiment with drugs in the adolescent age range do not go on to develop substance use disorders. So more good news. Experimentation in the adolescent age range is, by the way, considered developmentally normal, and again, not expected, but not out of the ordinary. And is not necessarily going to portend future problems with substances. But it is a concern, and it certainly can. So that's why we're talking about this topic. All right, so the use for all substances actually decreased during the COVID epidemic, so in the years 2020, 2021. And since then, substance use amongst adolescents has actually remained steady at the lower levels. So more good news. Kids who were in the 8th grade at the start of the pandemic will be graduating from high school this year. So again, if you're watching this, 2025, and this unique cohort has ushered in the lowest rates of substance abuse seen in decades. So substance use amongst our teenagers is actually less. Still a concern, however, as you can see by this slide. There has, even though there's been a reduction in substance abuse, there has been a dramatic rise in overdose deaths since 2010, actually, largely due to fentanyl, which is a potent synthetic opioid drug, a common contaminant, and counterfeit pills. Those are look-alike pills made to appear like legitimate prescription medications. Now, there are different ways individuals might ingest fentanyl, but for the adolescents, most commonly it is a contaminant in a pill that they were unaware contained fentanyl in most cases. So while drug abuse overall has become less common amongst young people, it has in fact become more dangerous. Okay. So we are going to look at the substances which are most commonly used by adolescents. So another one of those pretest questions. Alcohol actually is still the most common. These are, by the way, nationwide statistics. So in certain regions, certain areas of the country, amongst certain subgroups, populations, this may be different. But across the nation, alcohol remains the most commonly used substance by adolescents. Starting with 12% in the 8th graders, followed by 41% of the 12th graders. And that's if they have ever used. Followed by nicotine. Nicotine, 9% of 8th graders. We know nicotine these days is mainly being used in the vape form. although there are still pouches and standard cigarettes that are being used, but up to 21%. Still, and again, these are 2023 statistics, 21% of 12th graders. So nicotine and cannabis, the statistics are pretty close in terms of the relative risk. But 25% of 12th graders, 1 out of 4, have at least tried cannabis. And so that is a lot of kids. Other drugs which are being reported, cocaine, heroin, misuse of prescription drugs. So prescription drugs is included. They're all put together and relatively rare. Only 3% of 8th graders and only 6% of 12th graders are using these other, what we might call stronger drugs, street drugs, but also prescription drugs, which have been probably traded or stolen or on the black market and that kind of thing, maybe prescribed to the young person, but nowadays not as commonly. Physicians are very careful with the prescription of controlled substances and particularly opiates. So that is becoming less commonly the source. And then finally, the opioids themselves, Vicodin, OxyContin, Percocet, etc., just to share some common trade names that you might recognize. And the use of opioids or synthetic opioid drugs that data is only reported by 12th graders. And it was 0.6% using in the past 12 months. Whereas by comparison, in 2004, 9% were reporting having used these drugs. So all-time low, significant reduction in the number of kids who are trying these out. So that's good. We want to understand the motivation for using, and these questions have been asked of this same group. And most will say they're using in order to have fun or to experiment, see what it's like, or feel mellow, calm, or relaxed. So that's the motivation for most. However, there's a significant subset who say they are using, basically we call this self-medicating, using in order to help with depression or anxiety, or using in order to stop worrying or to forget bad memories. So when we move to the importance of mental health treatment and reducing the risk for substance use, this becomes more evident. So if we can alleviate some of these symptoms with treatment, whether that's psychotherapy, other treatment interventions which are effective, it has been shown to reduce the risk that these young people will turn to illicit substances in order to alleviate their distress. Okay, so moving on to an elevated risk for autistic youth. Autism actually has been shown, youth with autism have double the risk for substance use disorders. So there are a few reasons for that. But first of all, I just wanted to kind of share the reason why this has historically been under-recognized and underappreciated. Substance use disorders, the abbreviation, sorry, were historically thought to be rare among autistic individuals, which might be understood by the divergent culturally constructed narratives for the two conditions being autism and substance use disorders. The albeit naive portrayal of the autistic is that the individual is innocent or blameless, and again, kind of a stereotype, but whereas the judgmental and moralistic narrative of substance use disorder or people with addictions or substance use problems depicts that individual as corrupt and unworthy. So again, stereotypes and judgments, again, obviously not universally accurate in either of the two groups. However, a lot of times people do carry around these assumptions. And so therefore, with the opposing narratives, people just don't put two and two together and realize, hey, these young people are actually at elevated risk. And now to kind of try to explain why this might be. So autistic adolescents, autistic individuals share common risk factors that exist in the general population, actually at increased rates, more stress, negative life events, again, which any child or adolescent can experience, but more likely when you have autism. Also co-occurring depression, anxiety disorders, and attention deficit disorder. And so we know that autistic youth, autistic adults have higher rates of these disorders compared to the general population. And that might be contributing to the susceptibility for substance use and then subsequently substance use disorders. Social isolation compounded by social communication deficits can lead to difficulties with self-management, including a higher risk for substance abuse. Self-medicating, seeking relief from stressors commonly faced to calm social anxiety or reduce the discomfort experienced with social interactions. More reasons to explain why there is an elevated risk of substance use and substance use disorders in autism. So safety and harm reduction is a topic that we talk about a lot in substance abuse. There is a risk of using alone. SAMHSA, the Substance Abuse Mental Health Services Administration, and the DEA have a logo, hashtag one pill can kill. Individuals, especially individuals with no tolerance, can take one of these counterfeit pills laced with fentanyl, overdose, and unfortunately die. So this is an educational campaign, which has actually been very effective in educating young people about the risk of using. Adolescents are particularly at risk if they're using alone. Adolescents most commonly use with friends. About a quarter of them will say they use with their boyfriend or girlfriend or anyone who has drugs or other people. But then 50%, so some of those kids will occasionally use alone as well. So 50% of the entire population of kids who endorse substance use say that, yes, sometimes they do use alone. So that's a risk, especially if they happen to take one of these opioids intentionally or unintentionally, accidental overdose usually, and there's nobody there to rescue them. And so that's the concern, and again, an educational campaign. Don't if you're going to use, just please don't use alone. In terms of prevention, so ideally we want to prevent the risk of substance use disorder. Interventions related to providing additional support, learning how to manage stress, addressing mental health concerns might reduce these leading motivations for substance use among adolescents, right? 40% or so said they were using to relieve stress or to forget about bad memories and that kind of thing. So if we work on coping strategies, if we treat co-occurring mental health conditions, if we treat depression, if we treat anxiety disorders when they are diagnosed, effective treatment reduces the motivations for substance abuse, reduces the risk of kids turning to substances in order to try to figure out how they can feel better. Effective treatment of mental health conditions can reduce that self-medicating, and we want to make sure that these young people have access to effective, evidence-based mental health and substance abuse treatment in order to improve their outcomes in general, but decrease the overdose risk in particular. So here's the harm reduction in a nutshell. Dr. Nora Volkow is the director of the National Institute of Drug Abuse and has been for many years. And she has stated that evidence has shown research that delaying the onset of substance abuse among young people. So in other words, if the young person decides to experiment when they're in college, let's say, they're no longer under, direct supervision of their parents any longer. So opportunities, might present themselves that may not have occurred as much before they left home for college. But if we can delay the start of substance use or experimentation among young people, she said even by 1 year, it can decrease substance use for the rest of their lives. So that's interesting. So young people who might be experimenting at a slightly older age for the first time, for example, are less likely to develop an addiction. So when we get a history where a child has started to use at a very young age, then those younger children are at very, very high risk of going on to develop addictions as adults if we don't intervene. So that's just one fact to be aware of. It remains crucial to continue to educate young people about the risks and harms of substance use in an open and honest way, emphasizing that illicit pills and other substances may contain deadly fentanyl. Education about harm reduction behaviors, such as using in the presence of others, and providing expanding access to Narcan, which is the brand name for naloxone, to all people who use drugs or who affiliate with drug users could reduce the risk, could reduce some of these overdoses and fatalities. So just a note on psychiatric medications, because there's a lot of misunderstanding on this particular topic. Psychiatric medications as a group are, for the most part, not habit forming. You do not develop a dependence to most psychiatric medications. They are not addicting. And just a few exceptions to that. So we have stimulant medications for ADHD, which are in fact controlled substances, and that's based on historical trends when we prescribed more short-acting amphetamines and that kind of thing that people did sometimes develop a problem with, sometimes would abuse or misuse. And so we wanted to just make a mention on stimulant medications for the treatment of ADHD, which, by the way, are still first-line treatment for attention deficit disorder because they are the best tolerated in general and most effective. So a long history of evidence that they are very effective. Treating individuals for ADHD actually reduces the risk that the adolescent will go on to use drugs, and that's for a variety of reasons. So if they have more awareness of the risks of substance abuse because they're able to focus and they're able to be successful in school and other activities, they're less likely to want to go the route of doing things like using drugs that can sidetrack them from their path to success. So that's one thing. They have better self-esteem because their condition is being treated and they're doing better and so the treatment of ADHD actually reduces the risk for substance use. Now, if it's an adolescent with a history already of known substance use, then we should definitely consider non-stimulant medications. For ADHD, there are several to choose from, and there are other situations where we may choose the non-stimulant, and sometimes the parents that simply have the preference, let's start with a non-stimulant, and that's fine too, and they are not controlled substances. So parental supervision for stimulant medications. Parental supervision can alleviate the concerns about the potential for abuse of the prescription by the adolescent. And then these long-acting stimulant preparations in particular offer even less potential for abuse or diversion because of their form of administration. In other words, they're in tablets that often cannot be easily crushed. And so they're in a time release capsule, and they don't get it. There's a less a lower risk for reinforcement or positive effects if the individual is looking to get high or to get a certain effect from the medication, because it's in a time release and they only get a little bit over the length of the time release, which is either 8 hours, 12 hours, or in some cases 16 hours. And also parents can monitor because they're once a day medication. So child will take the medication typically in the morning at home. Parent will put the medication away and that's it. And they're covered for the day. So less risk of abuse or diversion. So as I mentioned before, treating ADHD improves outcomes. The American Academy of Pediatrics recognizes that children with ADHD are at elevated risk of developing substance use disorders. So just in general, children with ADHD, for a variety of reasons, ADHD is associated, there's a lot of thrill seeking sometimes associated with the ADHD, and then there's lowered impulse control. There's an increased risk for the child to be influenced by peers, and probably that relates to self-esteem. They want friends, they want to, and so they can be more susceptible to peer pressure. And then teaching strategies to help with ADHD, as well as providing effective treatment. So there's treatment aside from medication, but the treatment of ADHD, which can include medication, sometimes medication being the most effective component of the treatment plan actually in ADHD, improves both short and long-term outcomes and reduces the risk for substance abuse. So people sometimes feel like, that's you're using a medication that some people might abuse or even become dependent on to treat a condition. It actually ends up reducing the risk, and for the reasons we stated, because these treatments are very effective in treating the underlying condition and improves outcomes for the reason they're low doses, they're given in time release, they're closely monitored, and so individuals who have a diagnosis of ADHD who are receiving these medications, extremely low risk of actually any abuse of the medications. They take the medications for the reason prescribed and at the low dose, and they don't experience any euphoria typically. It's very beneficial in the long run. So that was another one of those pre-test questions. So hopefully that'll be helpful. And now I will turn it over to Dr. Ansari to finish up.
Thank you, Dr. Genovese. So here is one of the leftover part is effectiveness of family-based intervention. It's a systemic review evaluated the parenting programs to prevent alcohol, tobacco, drug use in children under age 18 years of age. So these are mainly the family-based prevention. It's a whole program. These preventions and interventions positively benefit not just the child, but the whole family, parents, siblings, extended family members living at home, and caretakers such as foster parents. So while they are implemented to improve generally one specific problem, such as substance use, they impact a broad range of other outcomes, such as improved goal attainment, school and job performance, and physical and mental health. So continuing with the family-based intervention approaches, the family-based intervention program include training in parenting skills are often provided to the parents without child present, and then to the whole family. The specific parenting skills that are taught vary somewhat with the age of the child or adolescent, but may focus on ways to nurture, bond, and communicate with the children, and how to help children develop pro-social skills and social resistance skills, reinforce rule setting and strategies for monitoring skills. So these are usually the family-based approach. These are like evidence-based. It's more than the supervision that we provide or the parents provide for the ADHD medication or monitoring or supervising their substance use. So these are pretty structured programs. Okay, and also the prevention program to focusing on family skills often includes sessions with the parents and children together that aim to improve family functioning, communication. So communication is pretty important, especially with adolescent with ADHD or autism. If they are using anything, communication with the family, and practice in developing, discussing, and enforcing family policies on substance use, like what are the rules and regulations. So there should be an open communication, and then they should develop some strong bond and have some policies on substance use among family. So this is the post-test. We had already talked about these. So that for the question one, the percentage, as we had already discussed, 10% in the 8th grade, 20% in the 10th, and then 30% in the 12th graders. And the most common substances by adolescent in the descending order is alcohol and nicotine, cannabis, and then the opioid. And as it says, untreated, or inadequately treated ADHD increase the risk of all of the above. They have poor outcomes in the life, academic underachievement, and the risk of developing substance use. And number 4, stressful treatment of mental health condition reduce the risk of developing substance use. That is true. These are some of the resources: SAMHSA, 911, 988, and Poison Helpline. And I think there's another one with the ACAP website that could be also resourceful. Okay, these are some of the references what Dr. Genovese has mentioned before.
Okay, thank you, Dr. Ansari. And we will wrap up. Hope this information is helpful. If you have any questions, please reach out. I'm sure.
Actually, Dr. Genovese, I do have a couple of questions that maybe I can get asked. One of the reasons I wanted to do this session, and you kind of mentioned it, but so many people that think just because an individual is autistic that they're not susceptible to having drug addictions as well. So I thought that this was really important. So I really appreciated both you and Dr. Ansari for joining me today and sharing some of this. But I do have a couple of quick questions. What do they think the reasons? I was kind of surprised in a way, but I guess not really. But that, and I'm happy about it. But how drug use has lowered in youth since COVID, is it just because of access? Do you think, or?
And Dr. Ansari may be able to help us with that too. The theory I read was that COVID brought families closer together, families with young children. A lot of parents, for the first time maybe in their children's lives, were at home with their children. They bonded. The children were heavily supervised. The children were spending more time at home, supervised by their parents. And when Dr. Ansari was explaining, the family-based prevention, I mean, that's exactly what was happening, but in a naturalistic setting. They were bonding, they were communicating, they were spending time together. And so that's what I read. Dr. Ansari, was there another reason?
That's true. And I don't know if it's evidence-based, but they were diverted or distracted toward another issue, which was much more severe than having a substance use issue like COVID, mortality, and all those relationship things. But family cohesiveness, that was the biggest thing.
I wasn't even thinking that. So that's really cool to think that. Yeah, and hopefully people will consider that. Again, if a parent was an addict themselves, we kind of mentioned genetics at the beginning, or you all mentioned genetics. If they were an addict themselves, should they be more concerned in watching, even though like maybe they've been clean for a decade or whatnot, but should they be more concerned in watching their children and be more susceptible to having an addiction?
I'll let Dr. Ansari answer that.
Genetic contribution is one of the biggest risk factors, like having a substance use diagnosis in any of the biological parents significantly increases the risk of development of substance use in kids. So there's a strong genetic, there are some molecules, receptors that are same. So it's a strong genetic heritability in kids who have parents with substance use disorder.
what I encourage in that scenario, and Dr. Ansari is completely correct. And so, I mentioned that experimentation in the adolescent age can be a normal phenomenon, but the children of parents with addictions or other close family members should be educated to the fact that if they ever use, they're potentially going to like the effect they get from that drug so much more that they have a greatly elevated risk of going on to develop the addiction. That's the other very high risk group. Besides the very young children starting to use, that's the other high risk group, but the children who are genetically predisposed are so I tell them it's a little bit like Russian roulette. You see your friends using this, you see them trying it, you see them maybe moving on later in life and it doesn't become a problem. But for you, I would recommend you avoid it altogether.
Is Narcan available for families to get and have? Like, is it pretty easy to get? They don't.
Doctor, I'm sorry.
So it's available in all pharmacies, but there are certain programs who also offer, like, for example, for adults, there are some housing facilities that provide free Narcan, like Oxford Living. For kids, I'm not sure if there are some agencies that provide free Narcan, unless they are enrolled in certain programs, but it's usually available in any retail pharmacies. And anyone who has substance use disorder, it usually pops up when we order any medication to consider Narcan, especially with opioid use disorder. But it's available over the counter, I assume, but every pharmacy has that.
Okay, so they can just go in and ask, because I could see families who'd want to have that just in case. And then last question for you all, and I'll let you go, is when we're looking at all of this, I know that we kind of generalized and looked at the data, but is there a big cultural difference? Do we see a lot of cultural differences as well?
Explain your question.
So is this like, looking at different cultures and how they raise their children, or how just everything, like, do we see a higher in white children in substance abuse, or Hispanic, or any other different cultures, I
Doctor,
guess?
I'm sorry again.
Yeah, so culturally, there will be a difference in what substance they use, especially with Hispanic, there will be more marijuana, African American, more marijuana compared to the white, which is traditionally more alcohol. So culturally, there will be drug of choice that will be different, but otherwise proportions will be defined by the risk factors like genetic heritability and other risk factors. But culture, there will be drug of choice that will be different.
So that's the difference. Everything is pretty much still the same. It would just be the drug of choice, as you
Depending
mentioned.
upon the risk factors.
Okay.
The other confounding factor with evaluating drug use by race is you have to take into account the socioeconomic.
Yes.
And so, yes, that's very much a factor as well. So, and lower socioeconomic, more stress, less parental supervision, sometimes single parent head of household, especially that would be a huge risk culturally, for example. So, but that's a good question. And there's a lot written about that. And, the gender differences, the girls used to be more so the boys, and the girls are definitely catching up, unfortunately. Again, not a good thing, but there are not as many gender differences anymore as there used to be historically.
But it sounds like it's going in the right direction, so I'm glad to hear that. But I did, like I said, I felt like this was an important topic. In general, but specifically for us families who have a child with ADHD or autism, and what that can mean. And just because they have those doesn't mean they're not susceptible to this too. So I want to thank both of you for joining me and sharing some information on this. So thank you. I appreciate you.
Thank you, Stephanie. Thank you, Dr. Ansari.
Thank you, Dr. Genovese. Thank you, Stephanie.
Thanks.
Bye-bye.
Bye-bye.